Hi, everybody. It's Dr. Eric Balcavage. We're back for another edition of the Thyroid Answers podcast. And today we're talking about AI, artificial intelligence. And it is not a thing that may be the future of healthcare. It's already the future of healthcare. And I was one who was very resistant to it in the beginning. I didn't think it could do what my brain could do. And I was, it's not, it's not good. It's not a good thing. But now I fully disagree with that early thought process. But we're going to get into a deep dive, kind of the good, the bad, maybe where we need to have some guardrails on AI technology. And I have two guests today. One is Dr. McDonald. He's a global leader in precision health, AI, and human performance, and he's the CEO of Precision Health Alliance. And the other is Susan Robbins. She's an epigenetics human performance coach who brings a deeply personal and practical perspective to how lifestyle and environment influence genetic expression. So, guys, welcome to the Thyroid Answers podcast. How are both of you doing today?
Fantastic. Thanks for having us.
Very well, thank you.
This is going to be an interesting conversation, and my listenership or viewership, wherever they're getting the podcast, is both clinicians and real people, patients, and it's where I thought this wasn't going to be the thing that people would use. Everybody's using it. There's not a day that goes by that I talk to patients that they haven't said, well, I Googled ChatGPT and ChatGPT said to do this. And I'm like, that might be okay for you. That's not a good recommendation. So it's not whether it's going to be used. It is how do we regulate and manage it? So I guess whoever wants to take this first, what's the good part of patients starting to use AI for health questions?
I can begin. Susie, you can.
Yeah, go ahead and take that and I can, if you want me to later, add in what I've seen out in the
I think you
real
should
world
both.
of people.
Yeah.
Yeah. So go ahead,
Can
Cam.
you start?
You start it off.
Good parts is, well, and obviously we're going to get into the accuracy of it later, but the good part, like let's just say that all is equal, accessibility to information is unparamount. And one of the things, it's a comprehensive understanding of what's going on is much, much easier to grasp when you're asking questions of a GPT rather than doing a Google search. Rather than, I even 7 years ago, I sat down in a doctor's office and he Googled my symptoms. It takes so long to sift through, which one's a paper, which one's not. Whereas you can be specific about the kind of search that you're looking for. And then you can ask about a specific thing. And then it's going to give you a fairly comprehensive answer. Or if not, you can dig a little bit deeper and it can give you more detail. So access to information is very, very helpful, number one. And having more people with more information, particularly, we'll talk about accuracy later and the kind of information it is, but more informed is good. Now, the mistake that we often make is that just because I have the information now, I'm going to be fine. Most people don't take action even when they have information. There's a really nice stat on 1 in 8 people diagnosed with diabetes will take action, even though everyone knows the kind of stuff that you've got to do to get there. So access to information, massive. Number two is the comprehensive type of information that you can get. It's just got a better memory than humans. So to ask the same question of another human, you're not going to get anywhere near the detail of the answer because one person may be an expert in one area, but this is where it has expert level knowledge across all areas. And so the ability to tie in interrelated ideas becomes much, much easier as well. This bigger picture thinking is very, very useful. And just the amount of data that can be crunched so quickly. You can look at historical information for the last 5 years. You can upload all of those files, a lot of stuff very, very quickly and gather just information at our fingertips is what it's all about.
Sure. And Susan, what's your take from a patient perspective? What do you see on a daily basis in your coaching practice?
So I see it more outside of my practice because we're really dialing people in my practice. But what I'm noticing outside, and this is where I really keep track in things like Facebook support groups around different genetic SNPs or different health conditions. And people say, well, I found this on ChatGPT. they're looking to diagnose and treat themselves through that. And I think it's a great source of information to get very basic things from. Understand what is an MTHFR variant? What is the ApoE gene? And so to get the basics of this is what this is I think really good. But where I think there's a problem existing is people are using it to diagnose and treat themselves. And it has no idea who they are, what their experience is, how things are currently expressing. And that's where I am, where I think it's, and I've used it myself to put some things in there and ask a question. I've also found that you can ask a question 3 times and get 3 different responses that go in different directions from it. So it's also understanding how to communicate with it to get the information that you're looking for. So I've seen it where they go down rabbit holes too far or in the wrong direction for them. And people have said that it gave me bad advice.
So the good part is that they can access information and get some foundational information. But yeah, we didn't really ask for the negatives, but we'll talk about it because we're going to talk about it more.
But on the positive, yes. Like I said, basic. The basic information, I think it's fantastic that they have access to that.
And the reason I want to get into the negatives right away, because we need to talk about context before we can start talking about some of like what the negatives are and why. So I want to kind of table some of that. But I think it's great for patients because in a regular doctor's visit, they go in, their doctor may not have even looked at their labs, may not have really looked at history. The nurse assistant may have looked at that and said, here's what's going on. And the doctor comes in this limited time frame, 10 minutes, says, okay, here's this, here's that, here's this. We're done. See you in 6 months or whatever. And patients today, especially with the access to the internet, I think they want more data. They want more understanding in many cases. And so I think it gives them the ability to get more data, get some more information about what's going on with their physiology. The challenge is what is provided as the strategy, appropriate or inappropriate. And that's what we'll get into it a little bit. Where is AI most likely to mislead people in their health? And I think Susan kind of started giving some examples of that, but I guess, Susan, for you, where do you think AI is most likely to mislead people?
Again, it doesn't understand the person. What are the specifics that person is dealing with? What are all of their genetic SNPs, not just 1 or 2 things that are thrown in there? What are the experiences they're having? What are their labs? You can throw some of that in there, but it's not taking in the knowledge of that person. They're coming in a lot of the times pretty blind, really having no idea. And not having that idea, again, I've gone in before we had our AI, I had gone in there looking for some extra information too, and I was seeing things that came back incorrect. And I thought, that's not right. So if you go in and you don't have that knowledge and you're getting this information given back to you and you don't know that might be incorrect or it could be incorrect for your specific situation, I think that's where you can have a problem occur right there.
Yeah. Pam, what do you think?
Yeah, there's an issue with the prompting. That's one thing. The bigger issues are how the engine is trained. So you can have, there's the 3 V's of AI excellence in healthcare. It's volume, veracity, and variety. So do I have a large amount of data? Do I have the volume of data? Do I have truthful data that's been entered into the system? And do I have variety in that data so that I've got lots and lots of different situations and use cases? And I give you an example. An AI may be built for a hospital to do with patient care, and they see a very specific type of patient. They have very specific types of specialists, and they teach it very specific types of rules. You then take that AI, which has been incredibly successful because it's been taught that environment, to another hospital, and it fails. Because it's now a different population. It doesn't have the variety of the individuals. It doesn't have the rules that are built for this new hospital as well, for example. So what you need, and this is how you get misled. There's another example of that as well. It depends on who's making the rules. So you might have somebody And that Google was a perfect example of that. This is a really famous one. Right when Gemini first came out, it was a very diversity first engine. And so when they said, "Can I please see a photo of Nazis?" It came up with a multicultural female group of individuals, which is incorrect. But the engine was told, "You must be diverse." And so it then, I've got to include lots of different races when that's not at all the case for Nazis. Right. So that rule is incorrect. That's a vector that they've put in. And so you could have one person who's got like a theory on the way health works. They've built an engine and it works with those rules, but then that's not a complete set of rules that then is going to account for all other conditions or the way that you're thinking about it as well. So there's a human factor with this, is who's built the rules. That's number one. Number two is there enough data to be able to compare and work out various situations? Because if it's only being taught a certain amount of stuff, or only has a certain amount of stuff inside the engine that it can relate to, then it can't extrapolate that to other things. And then it has to start making it up. This is where hallucinations occur as well, where it can just start grabbing at potential outcomes. So these three things are very important: volume, veracity. So is the data truthful? And variety as well. Am I seeing lots and lots of people in lots of situations? This is where big data is very, very helpful. But it still then needs the right vectors that are placed in by the humans to supervise the data the right way. Just as you were saying before, Eric, you need to know how things work to train it the right way. And there's another interesting example of this as well, is like when they're looking at insurance data, who should we insure for, who should be getting lower insurance, who's at a greater risk of having an accident. And it turns out that the name John increases your risk of having an accident based on the AI data. Yeah. So this is one example. And so per capita, anyone who's got the name John is going to have an accident more. Is that fair? This is a relationship that AI has come up with. Is it using the right rules? Or is it in fact, actually, it's a truthful thing? We don't know. And so this is where, what data are we using to come up with to discern, and this is where supervision, highly supervised AI is very, very important. But then that supervision also needs to be coming from a place of truth and expansive knowledge as well. So there's lots of different factors.
Yeah, who's supervising the supervisor, right?
Exactly. Yes.
And then for the listener, I think this is important. And Cam, you guys are probably more technical on this than I am, but like, from my perspective, I see this just within, let's just use the world of thyroid physiology. Somebody goes to their medical doctor who's trained a certain way. TSH is high, free T4 is low. They're diagnosed with hypothyroidism and they're put on medication right away. I would look at that totally differently and say, wait a minute, their TSH is high, their free T4 is low, but wait a minute, do they have hypothyroid signs and symptoms? Do we have lab markers that there's a cellular thyroid issue going on with liver, with renal function, with blood sugar regulation? And by the way, that's only a partial panel. So now we need to go say, is the free T3 low because they've got inflammation and elevated estrogen levels that are increasing binding globulin? So I have low free hormone, but the total hormone, which nobody ran, is normal. So therefore, we don't need to add more thyroid hormone in that situation because it could make the situation worse. What we need to do is to say, hey, the TSH is appropriately elevated, not because the thyroid gland hasn't made enough thyroid hormone, but because there's less free. And so it's two different interpretations. And that's where I see in my kind of playing with AI is exactly what you said. Who's teaching the model? Because in a medical model, if that AI was saying, hey, give T4, it would be appropriate for a management model that is most endocrinologists use across the country. If it was a management model in a functional medicine approach or an integrative medicine approach, they would say, well, yeah, give T4, but let's look at free T3. Maybe we need to give T3. Or maybe the scenario is TSH is normal, TSH is high, free T4 is normal, but free T3 is low. They would say we need to give T3 because that's the conversion issue. And I would say, no, that's an adaptation due to cellular stress. We shouldn't force the physiology. So we have to consider when we're looking at the AI, who's teaching it and what model are we trying to use? Is this based on a management model? Is that what you want? Do you want a recovery model? That's totally different. It's not that it's wrong, but it's different. And so that's where I see the big challenge for a patient who's just going on there. What is that AI assuming, right?
Mhm.
Does that make sense?
100%.
Absolutely.
That's exactly. It's who's teaching it the rules. It still is being governed by the person that's designed it, for sure. And in that way, that's also the safety mechanism in it too, right? Like, so we can teach it to be safe and do no harm, which is very, very important. But this is the difference between when it gets to sentience, as people worry about, and that's when it's really going to start thinking by itself. So which is how and when that happens is a little bit up in the air.
All right, next question, and both of you guys can take this one. Is AI changing the patient-clinician relationship for better or for worse?
I'll jump in there. I think the one of the most powerful and underestimated elements of the patient-client patient practitioner relationship is the amount of connection, is the level of, do I trust this person? Do I feel safe with this person? Do I feel like I'm in a place where I'm in non-judgment? Do I feel like I'm in a place where just walking into the office can be healing for the right practitioner and the right patient, because it's the time where they get to focus on themselves. I think that so much clinical work, particularly in Australia, where it's 6 to 10 minute consultations, very, very short time period, it's all on the content and it's not on the connection. And there's a huge gap in how effective anybody can be if they don't have connection with a person. And what this is going to do, firstly, it's going to speed up the access to information. And it's actually going to take eventually, and it's doing this already, it's going to take the information 90%, 95% out of the hands of the clinician. Like it's going to be, hey, I should check that. This is what we're going to be. And if we're not checking it, it's going to be negligent. This is the really interesting thing as well, is that the comprehensive thinking of the differentials and the other possibilities that could be going on. What else could be going on for this person's health, or what could be driving this person's health? If we're not checking, it's going to be negligence, because there's more stuff than what we can hold in our head. What that then does is it frees up time to communicate and translate that information. And that requires connection. So the change that's going to occur is you're going to have practitioners survive if they can connect. If they can connect with their patient, if they truly care, if they're not just here on this treadmill, just churning out patients and just giving out a thing or whatever it might be, but rather to say, hey, right, I've got the information here. I've got to make sure this person can really go and really do something powerful with this information. I'm going to translate it well. I'm going to make them feel safe. I'm going to help them understand it. The way that health professionals are going, they'll become excellent, excellent coaches. And this is what we need. We need a lot of really, really good coaches at varying levels of knowledge to be able to translate information so that people can feel connected to the information. Like when you actually do a proper coaching session, and Susan will know this just as well as anybody, you might have a 20-point plan to be able to support this individual, but their capacity in the change that they're going to make this week is half of one of those points. And you've given them a 20-point plan. They've walked out, said, there is no way I can do this. They burn themselves out after a week. They don't come back. They don't take the advice. They're not connected. It didn't meet them where they need to be met. This is going to be a situation where health professionals, it's going to force them, purely because their value is no longer going to be so much on the knowledge. It's going to be on how well can I connect this information with the person and help them take action. So there's going to be a huge movement towards coaching. That's the direction. But there's a medical coach is a very different person to a behavioral coach. But it's still coaching. It's still behavior change. It's still translation. It's still connection. That's the big shift that it's going to happen, is more people are going to be connected, in my belief.
Yeah. I think it's interesting you use the word capacity. We'll bring that back up later, because I think that's one of the big challenges with strategies. It's about capacity. It's about state. It's about capacity when we're doing things, but we'll come back to that. So, Susan, what do you think? You're working with clients on a daily basis, so how do you see it? I'll let you answer, and then I'll give my commentary.
Sure. I see the positives again and the negatives. And the positive, again, I think it's creating a much stronger bond between the coach and the client for me. You can't take away that personal relationship. People, because everything is going so technology based, just even communication with individuals, with relationships is so much less that when that person comes and meets with me, like Cam had said, that's their time. They want to feel seen and they want to feel heard and they want to feel special. And AI doesn't provide that for them. Some say, well, it can make me feel good. It tells me I'm awesome and all, but it really, it's having that person that you build that trust with. Because a lot of the time also people aren't ready to come, but for lack of a better word, to come clean with what's really happening. What are they really doing with their lifestyle? Because that's what I work with. I like to say I'm an epigenetic human performance coach, but I'm a lifestyle specialist. I stay within my lane there. It's all things lifestyle. And that's where people don't want to be judged. And so when you can build that trust with them to where they're very open and it allows you to dig deeper, whether you're using the AI, the relationship is what changes it, utilizing AI to be able to go deeper within those lifestyle parameters that I use. And Cam also addressed this. I was taking notes in my own with my own mind of the things, and Cam's touching on that. So it helps us dive in deeper and quicker, where it would take me sometimes days because I do DNA testing. I use the PH360 platform, and then I have my own personal knowledge and I have the information that's coming to me. It could be giving me heart rate variability data, sleep data, trying to put all of this together. It's very time consuming, and AI is great in helping to lessen that time that I can get back with a more comprehensive plan for my clients. Where I think the issue goes, I'll have clients come back to me and say, well, I got into ChatGPT and started looking deeper, and it said to do this, but you're saying to do this. And I said, well, but this doesn't know that you're experiencing this. And did you put all of your DNA SNPs in there that are referring to this? Well, no, I just said this is what I was just questioning this. And so I have to kind of say, I'm going to reel you in, my little minnow, reel you in a little bit and trust me to work with me. Let's do this together. So that's where I think, again, it's having that relationship with them where they trust you enough to know that you understand how to use this properly, and unlike the direction that they're going. So that's where I see the pluses and the negatives with it.
Yeah, I think it's great because for a lot of people, they're more engaged in their healthcare because they're searching for answers and they're coming to you with information versus just coming in and saying, hey, give me a supplement to fix me. They're saying, hey, now I've found out this could be that, this could be this. What about that? I think it's great because I think it brings a more engaged patient. I do think it creates a little bit of frustration talking about what you're saying with they're getting information from something that doesn't have full context, right? Taking something, this thing says to say, take this based on the labs, but yes, it doesn't understand your current state. You're in an overloaded state. Adding mitochondrial support right now is probably catastrophic for your overall physiology. That's not where you go. I understand why you may think that, but here's why. So it helps me from an educational process. It just does help with that communication. I think where it's challenging the doctor-patient relationship is many physicians are just used to being the boss and saying, here's what we're doing, and that's the way it is. And when somebody comes in and starts to question them, if this is about you being the boss of the patient, you're in trouble, because now that patient has just spent 30 minutes, 3 hours, 30 days studying about their symptoms, their signs, their questions, their concerns. and they may come in more educated than the physician who's treating them with knowledge. And that's very off-putting for a clinician, for somebody to come in and say, you put me on this. Here's all the side effects. Here's the problem. Those are all the symptoms I'm having. Why would you do this? Why wouldn't you use this drug or medication? And if for the wrong person, could be very, very challenging for their physiology. So for Cam, I think this is good. You're correct. This is going to be all about good relationships with clients, which is what it should have been all along. And it is going to take a practitioner who's more robotic and maybe just follows kind of what the rules and the guidelines are and doesn't have a personality. And they're going to potentially lose a job and a career because they can't adapt appropriately. They were a very good machine. I do this. This is what the book says. This is the diagnosis, the treatment, boom, boom, boom. But with AI can do that very simplistic kind of, here's the recommendations. They can't prescribe it, but they can get a lot of that data. What they really need is the explanation, helping them kind of understand the physiology and making that connection. Here's why we're doing this. Here's why you're not quite ready. Here's why we made this decision. And here's what we need to do next. But it is going to be about good communicative skills and creating that bond. And I think that's where it's going to really help.
Agree.
So if you have any disagreement, that's fine.
I'd say one more thing on that. And that's it came out of an MIT study looking at AI radiologists versus human radiologists. And AI radiology was at 92%. The human radiologists were at 74% accuracy for looking at scans. And then when the radiologists were given the AI to work with it, they got 76%. And this is because, they've only increased 2% when AI is actually doing it pretty well. And this is because there's an ego associated with it. And I've used AI in this way too. It's like I've put in a bunch of stuff and I've said, well, that's obvious, like what it's giving me back here. So surely it's got to be something deeper and more complex than this. There's something that the AI hasn't considered. It's probably the obvious thing, and this is where you say, oh no, I must be more clever than this machine. Yeah. And it's that little piece there that's going to take a little bit of unwinding. Exactly. That more robotic practitioner or the boss man type practitioner, there's an ego that comes along with that, which has been very, very good because that certainty actually makes people feel safe. So right. having a sense of like a real strength in conviction. So it's just about what they are strong in their conviction about. It's like, and probably the thing that they need to be thinking about is, do I have an AI that's trained the best? Because that's where the answers that come out of that AI versus the standard one that other people are using, that's when you can maintain the boss status because you can say, hey, look, I understand your AI over here, but we've got more context and we've got better rules in this AI. So it's not about what AI, it's about or if AI, but rather what AI. That's another important thing to be considering here too.
Yeah. I did a podcast with somebody. We were talking about treatments for cancers and the new strategies. And we were talking about the software and stuff. And I asked him about AI. How is this going to change? He's like, it's not how is it going to change it? It already has changed it. He said, we couldn't be doing what we're doing at the speed we're doing it without AI. He's like, there's just no way. Because we can do a scan and within minutes, seconds, we have an answer for what we need to do, where before that person had to go here, get treated there, get a report, somebody had to analyze it and come back. He's like, that's done like this now. And it's more accurate than it was before. And so it is it is here. It's just, how are we going to use it and are we going to use it appropriately? So I guess next question, and maybe we've talked about this a little bit, but I'll give this to Sam or to Cam. If AI is used well, where do you think the biggest upside is going to be in healthcare?
That's a great question. This reaches into our vision. We eliminate chronic disease and we increase connection. If AI is used maximally, literally what's going to be happening, and this is on our roadmap, you will have your VR or AR goggles on, like you've got your Facebook Meta glasses on or whatever, the Samsung ones. I'm just being brand agnostic here. Yeah. You're walking along It's looking at your HRV. We're actually doing a number of things in how much data can you actually pick up from, the lights on your watches and things like that. There is an incredible amount of data that you can actually extract from the watches. And if it's got a background understanding of your body with genetic information and good context on phenotype and all of those types of things, and then it's watching you and it says, oh, hey, Cam, your HRV has been a little bit dysregulated for the last 2 hours. Normally, your body tolerates it well for 90 minutes. It's been an extra 30 minutes. On your way to your next meeting, what I've found is that the combination of these 3 things really help you regulate this. Firstly, I'm going to play some music and I want you to breathe at this timing right now. I also have ordered a green tea for you because that seems to regulate you too. And I'm going to play this song because it always seems to put you in a more connected mode. And so all of a sudden now, instead of going 10 hours of dysregulated heart rate variability and therefore cortisol levels and therefore like sort of system-wide dysregulation, I nip it, I recover it, and I'm back to square. Now, that can happen as well with, hey, we just noticed that your blood sugar went up a little bit. I need you to go for a walk for 5 minutes. I just need you to walk on the spot. Or I've activated your treadmill, or I've pushed your meeting for whatever. It's I'm going to make this change. I'm going to manage your health now rather than wait until symptoms emerge in 7 years' time. I am going to look at this micro symptom right now. And it's like, great. Oh, and I'm not encouraged to do it. The AI goes, okay, he didn't do that last time, but this is becoming more important now. So what are the things that he thinks are actually really important? And this is where we can start predicting this with behavioral genetics and behavioral tendencies. It's like, oh, maybe there wasn't enough family involved. And so it'll reshape its strategy to make sure it gets the outcome. So this is where it completely changes how we interact with our health. And then what it allows, so there's a couple of things that come off the back of this. One is you then become acutely aware of, oh, I've been in a dysregulated state for the last 2 hours. I do feel a bit funny. It becomes a really powerful in the moment mindfulness tool to say the state that you're in right now is slightly dysregulated. And so people start getting feedback in real time about when they are in and when they are out of flow, which then starts informing them about, oh, I'm feeling a little bit off. That's interesting. Okay. And my alarm rang. It's like, then we start getting ahead of these feelings as well. And we actually start having a communication with ourselves, because I know my kids are going through school right now. They're definitely not being taught to read their internal cues that way at all. Like they're just being told to sit still, be quiet, and do your work, rather than how am I actually feeling? Do I feel connected to the people around me? Am I feeling a bit hungry? Did lunch disrupt me a little bit? Like we're not giving that education. And so that education can become real time. The second thing, unless you want to jump in there, Dr. Derek, but I could feel your lips formulating a sentence. No, you're okay.
Well, I will tell you this. It's a question I had later, but listening to you say it's part of it. I'm sure there's people that sounds great.
Yep.
I know there's somebody else sitting at the other end of this going, that is going to create more stress in their life. I've got so much on my plate, and now I've got this thing in my ear that's going to be telling me, you got to do this, we're doing this, you're doing that, you got to do this. How do we keep the technology from becoming another part of the excessive stress load versus being supported? That's, I think, the key. And then the other question I had is, we have a lot of this measurable stuff that we wear all the time. It's not as accurate as it could be. And are we sometimes basing some of the data, although it's maybe the best we have, that maybe the ring I have on my finger is better than the watch I have on my wrist because of airflow and things like that? I know it's going to get better. You know it's going to get better. At some point, somebody's going to start putting implantables in there so that, hey, you don't have to worry about the watch. It's just constantly reading. But I guess the first question, how do we buffer this thing, have these kind of bumper guards on the bowling alley, so it doesn't become another part of somebody's excessive stress load?
So there's 2 elements to that. One is it learns. And it goes, oh, I've just been hassling this person for the last 5 minutes and now they're more stressed. So that's a bad thing. I've got to change my strategy. And this is where it learns. Second, there's implicit versus explicit instruction as well. So, and the implicit is, I'm walking along and this music that just makes me feel great turned on. That's weird. And it's like, oh, geez, I feel better with that music. Now, I would like the machine to say, hey, Cam, your HRV's a bit up. And this music's got this crazy tonality that seems to influence your auditory cortex and change the way that you're feeling about things. And I go, whoa, that's amazing. This music's incredible. Thank you for explaining that to me. Somebody else just wants the music to be played. And so they're not getting an instruction. It's not taking more cognitive load. It's just going to play in the background and it's going to change their brain. So that implicit versus explicit becomes very, very different. And this is the same thing for when you're in a relationship. And this is another way that it actually supports you. But I'll just give an example from a relationship perspective, because that's what you're actually forming here, is a relationship with AI. And that is, if someone comes in, let's say it's a husband and a wife, and the husband's just learnt some emotional intelligence, which is really exciting. And what they've got to do is they've got to validate what the partner is saying first, just to say, oh, I totally hear what you're saying. And then they're going to ask a further question to extract more information and to ask how they're feeling. And they're going through this checklist in their mind. Now, when this husband's in the first throes of doing this exercise, they'll be saying, oh, yes, no, I've got to validate you. So yes, I hear you. You know, like they're going to be explaining it as they're doing it. And the partner's going to be going, oh, I can see what you're doing. You're going through your checklist of emotional intelligence. It feels okay, but it doesn't feel great because it's explicit. As opposed to the partner now has been doing this 6 months and they're starting to rock it. And they come in and they almost imperceivably just acknowledge and validate in a really, really loving way, with a hand on the leg, with a really interested look. And they're not explaining what they're doing now. They're just doing it. They're putting this person in the environment that feels best for them, a validated environment. This is the same thing that goes with overwhelm. One will cause annoyance and overwhelm with the wrong person. Another one is just, man, this is the environment that I want to be in. So, and what's really interesting about that, and that was the second point that I was getting to, was when you've got two people interacting, and we've got a relationships component to what we do at the moment as well. We can say, oh, Eric is my buddy, and we've shared our data. And so Eric is having a bad day. It understands Eric's natural tendencies. My app is communicating with it and says, Eric's having a bad day. You're about to catch up with him. He might like to hear this right now. And just to say, hey, Eric, how's your day going? And if he doesn't respond, you might want to just change the topic and really distract him. But you might also open up the conversation to say, hey, man, is there anything on your mind? Or another instruction where you actually say the right thing to your partner instead of just come in and put your foot in your mouth and make a big mess when some people are stressed. Like there's this idea of, I actually start to get some insights on the people around me as well. And then when we think about our human experience, when you think about blue zones, when you think about what are we actually here for, it is to feel connected to each other. And you can disconnect yourself so quickly by saying the wrong thing at the wrong time, even with the best intentions. And this is where there is a framework that can support an individual to say the right thing at the right time. So when we're talking about AI, I know that we always think about the tech, but it has the capacity to connect us like never before and teach us about each other in a way. Like we're doing this with schools right now, where you can literally set up a conversation with one child and you can ask the AI to operate like their peer, and you can have a conversation with the AI face to face about why you're acting this way. And the peer AI is able to give insight into, oh, well, I'm feeling like this and these things are coming up for me. And then the student goes, oh man, there's so many other things that I didn't consider about why this person's acting the way that they are. We don't take that gap. We just react often. And it's these little interfaces which allow us to pause, just like a clinician. It's like, oh, I think it's this, but it's like, I should pause and actually ask. And there's 7 other things that it could be as well. The same thing's going to happen for relationships too. So if we are heading towards a world where we're more connected, and sorry, I do ramble on when I get on these topics because it's very exciting.
Because you kind of answered the next couple of questions. It stinks for Susan because we already got those answers. Can AI support lifestyle awareness and behavioral changes? And the answer is yes, right?
Yeah.
And can AI help people engage earlier before disease develops? And we already answered that one. So that's awesome. So we'll just keep going. How's that?
I love it.
So
beautiful.
I think before we go further,
That was very explicit interviewing, by the way. I'll just,
yeah. Did you see how that was?
Yeah, it's good. Perfect example.
It's funny. Some of the things you were giving examples of, I'm writing a new book. And so some of those things you were talking about, the pause and all those things, I've heard of emotional intelligence. I have an aunt that does something with it, but I don't really know what it is. But I think it's when doing this work, and probably Susan would agree with me, that a lot of what impacts our clients and keeps them stuck is they're wound, their load's excessive, the amygdala is uploaded, they're in constant. And when I was on Susan's podcast, we were talking about the cell danger response, but that's not really where everybody lives. Where, we think of this state I call resiliency, like that's the optimal state, right? Very few people are there. Most people aren't in cell danger response either. Where they're at is they're in a chronic strain state where they just don't even realize how much load is on there, and they're adapting. Some are adapting well, and some people are really adapting poorly, but that's where most people live. But when we're in that mode, it is hard to have communication. It's hard to make change. And so what we need to do is kind of help people through that process. And maybe AI is going to be the thing that helps encourage them and keep moving them in the right direction so they don't wind up in overload and cell danger response. But I want to keep this moving because we're going to run out of time. So I think before we go further, I think it's important to clarify something foundationally, because we're talking about AI providing health advice, right? AI helping us with well-being. So we have to have a definition. And I don't know if the healthcare industry really has a good, clear definition of what health is and well-being is. So as an expert, Cam, I'll start with you. As an expert, how do you define this? Like, you're working and creating AI and telling it this is what health is. What is health from your perspective, or the AI you're teaching's perspective?
That is a great question. So in its simplest form, it is living a life in alignment with an environment that is aligned with your natural preferences and tendencies, and having the capacity to adapt to changes in that environment and then come back to homeostasis. And I guess that's a basic physiological one. That is to say, you will be healthier if you're in an environment that aligns with your body. For example, and I'll break this down because there's a few components, and I might just give a bit of a summary first so I can come back and track through these points. So number one is, am I aligned with my environment? Number two, do I have physiological resilience, as you were saying, physiological adaptive, metabolic flexibility? Number three, do I have an effective immune system? Number four, do I have connection in my life that is of value and that is showing me more of myself and allowing me to unpack more and more of my self-understanding? And then five, I would say, do I have meaning and purpose, and am I working towards that in a meaningful way using my natural strengths? So this is where there's and this, I took that last one from positive psychology. Seligman and Csikszentmihalyi came up with a great model for what is great mental health. Great mental health is living a meaningful life, working towards something that has purpose and meaning, and also working in that in a way that you engage your natural strengths. I think that's very, very important. We talk about that in schools a lot with kids. Who am I? What are my natural strengths? Etc. So that's a big chunk of it. And that's like doing work that you love, interacting with people that you love, but doing it in a way where you feel celebrated for just who you can be and just who you are generally. We then come back to the environment. We know that some individuals will, and I'll give you an example. We had an individual, she was doing the right kind of exercise. She was really responsive to high intensity interval training. She was really good at eating regularly throughout the day. She was doing her 5 meals per day, and that was working for her body. She was connecting with people around her and had some really close friends and connections, and that was feeling really, really good. However, she was living at altitude, and Susan can relate to this. It's not Susan, but she essentially had these chronic symptoms that were bothering her, like nosebleeds and headaches and issues for 10 years. And it turned out that she was living at the wrong altitude. As soon as she moved down the mountain, her symptoms started resolving. And so what I mean by living in your best environment, there are absolute environments that are better for some individuals. And you can try and resist. Like if you're a very, very cold person and you're living in a very, very cold environment most of the time, it's a mismatch for and what I mean by cold is those people that don't tolerate cold well, and they're just constantly in a state of cold. Yes, you can put rugs on. Yes, you can put heating on. But every time you go outside, there's a little bit of extra stress compared to somebody else, like a native Greenland individual who is absolutely robust to the cold. They absolutely love it. Get me out in the cold. I feel great out there. And some people actually thrive in exercise less than 15 degrees Celsius, which I can't do the conversion. Sorry, Fahrenheit's too confusing. There are frank environments that are good for people, like sprinting for Usain Bolt, great environment. Sprinting for a sumo wrestler, 400 meters, terrible environment. Like that's the wrong environment. And so firstly, knowing what your best environment is, putting yourself into that environment as best you can. That's where you're going to heal. That's where you're going to recover. So there is a preference that is built into your genes and your phenotype that needs to be acknowledged, and it's not acknowledged anywhere near enough. Number two is, do I have the metabolic flexibility to adapt to something that's a little bit out of left field? Like, oh, I've just had a cupcake. Can I tolerate that? Is my metabolism at a point? Have I moved frequently enough? Is my signaling good enough with my insulin to be able to tolerate that cupcake, be able to enjoy it, have the pleasurable life for a moment, and then to be able to metabolize it and go back to normal and it not disrupt my chronic disease risk later? That flexibility is very, very important. Can I run up the stairs and not lose my lung outside my mouth? You know what I mean? Can I just move my body for my kids? Can I move it intensely? Can I go into emergency mode and not tear a muscle? And that comes through regular training. It comes through putting yourself into a space where you are testing your body and challenging it. But if you challenge it in your strengths, and we see this from the literature as well, I know this is a very long answer again, but there's a lot to good health. You can take a person that's got the genes and biomechanics of being a very, very big weightlifter. And when you make them run and do endurance activities, they don't benefit as much. But if you give them weights to lift, they benefit a lot. And this is because our bodies have a predisposition for the type of exercise. They actually get better results with their strength and their fitness if they're doing the exercise that matches them. And whenever I'm doing a talk, I ask, who hates running? And 30% of the room put up their hand every single time. But running is the panacea, It's that's not the case. Some people hate it because it makes their joints feel sore, and because they don't enjoy the monotony of it. They need more variety or whatever it might be. So we have natural strengths, and if we train in our natural strengths, we get a better result. If we are working in our natural strengths, we get a better result. So, and then if we're in an environment that matches our natural tendencies, we also get a better result. And it means that when we get tested, we recover faster as well. So there is an innate bit that's determined about our body. We can only adjust so much based on the capacity that our genes have, and we're all different in this sense. So, but they're my, just to summarize again, it is be in an environment that matches you, test yourself in your natural strengths, and strengthen yourself so that you have adaptability and flexibility, both physically and metabolically. Be in a relationship. We didn't get to this, but that's a conversation for another time, where you can actually grow.
Because all of these things that you're talking about are what are components of health, right? But yes. What is health? So,
well, no, but this is what I'm saying. It's just 1 second on that, because the idea that you're in a relationship is the marker of good health. You can check that physiologically, but it's being in the good relationship is the marker. That's what I'm saying is that you can mark yourself on your health if you have good relationships, as opposed to I need a physiological justification for this, because the physiology will match it. That's what I'm saying, is that this is not just a behavior. This is actually a determinant. And so that's the way that I'd pose that to you.
Yeah. So when I think about health, right, I think there's a lot of what I call fitness factors to go into composing a state of health. For the listeners, I'll just give you the definition I typically use. And then, but I do think relationship fitness, respiratory fitness, emotional fitness, physical fitness, mindset fitness, intellectual fitness. I mean, I cover 18 things at this point with individual clients. So I think they're all important. But you tell me if you agree with my definition, or where do you think I should change it? Because I think this is one of the people, everybody says, well, I'm healthy. Why? Well, because my doctor said I am. Based on what? My Chem 14, and he put me on a blood pressure medication and a statin, right? So, but people want simplicity. So my simple answer is the capacity of the human system to adapt efficiently to internal and external demands while maintaining stability without excessive cost, right? Because there's things that we do that we like to do for health that are demanding, but help us heal and recover. And there's things that we do from a health perspective, like you were talking about the mismatch of the person doing high level training at altitude. She can do it, but her ability to maintain stability came at an extreme cost for her, right? And this is where we have to have that conversation with our patients is you're doing cold plunge, you're doing sauna, you're doing HIIT, you're doing muscle training, you're doing all these fantastic healthy things to optimize that everybody says is great, but there's no recovery here. You're doing that at the cost of your relationship. You're doing it at the things. So what is the cost to get this, what you think is healthy? And is the juice worth the squeeze? You know what I'm saying? So that's where I think for people, that's resiliency, right? I have the capacity to strain myself and still maintain stability, and it doesn't cost me much. But if it costs me a lot, like, hey, I can do all this exercise, but it's going to downregulate my thyroid physiology, or it's going to create excessive inflammation. That's a health strategy, but not for you because the cost is too great. So just my opinion. If you guys want it should change or get a different opinion on it, I'm more than open to it.
Perfectly aligned.
I agree with it because this is what I do with people is work with that. And it was funny because when Cam was talking about the altitude girl, I thought it was me because I live in altitude. I train in altitude. I do the 5 meals a day and I'm a very, very avid hiker. I live at nearly mile high and I'll go to sea level. I'll go to Texas and my HRV will shoot up overnight. My body battery and my Garmin will recuperate 100%. I didn't get to some of those numbers until this summer. And it took working with this to find out how to best work with my body so that I could actually get the recovery. And then interestingly enough, and I had my heart rate variability up in the 70s. And it was telling me that I was unbalanced at first because it wasn't normal for me. I was getting great recovery, feeling amazing, was able to lower thyroid meds. It was like, this is unbelievable. And then the cold weather came in and I detest the cold. My body hates the cold. And I have steadily watched my HRV come down. And without changing anything and keeping up my activity, I see my weight go up about 3 pounds. And it's because of my body trying to adapt to somewhere that is not ideal for how I'm created. And I think that these are the enlightening things. How do I work with this? How do I adapt if I want to stay here? Is this the ideal place for me to live? In my mind, yes. In my body, no. Right? So the more we can understand about our genetics, our phenotype, and this is how I work with people. Are we in even just the right surrounding within our homes? Is there so much clutter that it's creating chaos in my brain that's creating more stress in my body? Living in relationships that are toxic, all of these things.
So I'm glad you said that because what I was going to say is this genetic predetermination? Or is this the amygdala because of past experience, learned behaviors, mother, father, teacher, preachers? The amygdala is saying, I sense cold as danger. I sense cold as threat. And that creates the change in physiology before you even think it. Not that it's emotional, but this chaotic environment already, as soon as I come into it, my amygdala looks at this and says chaos, right? And you could say, well, I've got some genetic predispositions. Obviously, a lot of people do. They may have a harder time metabolizing fight or flight hormones. But I think there's a lot we can do from a brain and biologic and amygdala standpoint. Like, how do we reduce the danger response, which is all part of what we were talking about on your podcast? How do we get this brain to start signaling less danger, because what we do is we spend the better part of our life training this amygdala, which shouldn't be as active it is for most people, of what danger is and what danger is not. And especially as we start creeping into that chronic strain state, our brain starts to perceive almost everything as threat and danger. Everything's the hill that you need to defend. Everything's the hill that you want to fight and battle for. The dish that somebody left on the counter becomes the argument between the partners. And they think it's about the glass on the counter. It's not even about that, right? It's about the meaning behind it. But I think there is a connection there. And when Cam was talking about there's an environment for it, I think we have to be aware of the two, but we can adapt to it. But to some degree, if part of our physiology is saying, I hate cold or I hate the heat, that already starts to have an impact on how our physiology works before we're even thinking about it.
I'd say it's always a combination of these things. Yeah. It's never just one or the 100%. Other. And I mean, the very bare basics of it are that, and this is from like my background is exercise physiology and dietetics, and there's some really nice studies looking at genetics and exercise response, and you can put twins through an exercise program, and we see every single time 15% of people doing running training get less fit. Their VO2 go down. And it happens consistently across data sets every single time. Like it's crazy. There is definitely a type of person, their body goes into a stress when they run. And this is because it's been repeated so many times. It's biomechanical, it's muscle physiology, it's cardiovascular mechanics. Yes, there might be a component of I really don't enjoy running, but there is truly a relationship between my body is built for this and my body is not built for this. And you will definitely talk to people that know that they are not built for it. Then what I see is, particularly from a trauma perspective and a stress perspective, is that when you get a person into their preferred physiological environment, their ability to heal and engage with those traumas and to de-stress is much easier, because you can't deal with subconscious patterning while you're in a state of stress. You have to be able to have a highly mindful moment to be able to feel and interact and then integrate. And if you're not in an environment that isn't safe, isn't trusted, isn't comfortable, isn't allowing your physiological systems to dial down, then you can't get in and access those things. So
I totally agree with that.
So the conversation around what causes more strain is where I really love your definition, Eric, of is this causing too much strain for the individual? Well, we can start predicting, and that's the natural strengths piece, is if you're in your natural strengths, it causes less strain. Whereas if you're outside your natural strengths, it causes more strain. Yeah. So I think there's a lot of alignment in what you've said.
Yeah, I think it's good. And I could stay on this topic for a while, but I want to get to a bit more things. So we'll try and do like a little bit more rapid in the last 40 minutes that we've got.
Love it.
And so we can get through to the end here. If we had 2 more days, we could spend 2 days doing it.
Let's do it.
So let's see. Let's do this. Cam, maybe a great question for you. How should AI define normal physiology? We hear these terms like normal physiology, optimal physiology. Like, how should AI define what's normal? Like, because if you like we talk about the lab reference range, and the medical community say that's the norm. The functional medicine community would say if it's within this lab range, it's the norm. I don't believe either one of them is right, because labs need to be interpreted based on the state. And sometimes a lab value could be normal and it's appropriate. It could be normal and inappropriate. It could be abnormal and totally appropriate, and abnormal and inappropriate. So
yes.
What should AI be doing?
It should be, the best way to answer this is actually talking about what we're doing. And that's, it should be accounting for, so essentially what we've got to do the very simple, and this is in JAMA, Journal of American Medical Association, that is, randomized control trials are ineffective at providing insights that are for personalized healthcare. So this is very important because randomized control trials provide average results. And this is what the average will happen. And we assume that everybody in this trial is responding the same. This is the biggest misnomer, and this is why it will change with personalized algorithms. So personalized algorithms will determine what normal is, and the AI will be doing this, but it will be doing it with excellent knowledge to start with. And so what we've done is we've collected now 3 million human years of phenotype data, looking at lots of different markers for these bodies. We've layered in the evidence that sits across each of these markers, so that we then have a very, very powerful working definition of how are people different. And then we've got data that matches up with that as well. But then we need to go one step further, and this is where we have a blinded panel of over 80 different experts in different fields of conventional medicine, and there's double ups and triple ups and quadruple ups in some fields. And the idea is that they get blinded clinical rationalization thinking questions where they give their answer, and then multiple people are giving the same answer, or to an answer to the same question, and then there's differences in that opinion, and then in a blinded manner the answers go backwards and forwards. And some of the questions are being asked, in fact what we've spent a lot of time on, is if you've got this blood marker, what does it mean for this person at this age, at this stage of life, with these things going on in their life? Is that normal or abnormal? And give the justification for it, for example. But then we've also got data from the human data that we have to say that this particular phenotype, their hematocrit should be moderate to high. And because generally this group are moderate to high, and even the physiology indicate that too. But then we have individuals that should have a moderate to low hematocrit as a normal range for them, because their body, this is the way that it compared to others, this is how it produces those various cells. So in the data, we have some bands of norms that allow us to understand, hey, you've got a particular phenotype, your tendency is to have this, so we've got to account for that in a precision range. But then we've also got a clinician or multiple clinicians that are specialists in that field that have been looking at ranges from a functional perspective to say, well, what is a healthy range for these individuals? But then let's take into account these other factors too. And then we've got the normal like longevity ranges as well, which are the standard practice. And so this AI, what it's got to do is triangulate this information, because no clinician can do it. No individual, no paper will be able to summarize it. It actually needs to be a free moving thing, but it needs to be informed on real human data, looking at it in the right way, evidence base, clinical input. And those three things need to come together. And this is what couldn't be done before. And so at the point now, you can ask the engine that we have for a precision reference range, and it will give a very tight reference range for the individual. And that will shift slightly depending on the person that you're looking at as well. So that would be my answer. It actually needs a few components, but it should be giving us a precise normal for this individual based on a comparison to all other data.
Yeah. And I think that's good, because it has to be individual based, and we have to take everything into context. I know for the listeners, like when somebody sends me a thyroid panel and says, what should I do? I'm like, I have no idea. Well, what do you mean? Well, because I don't know what your medication dose was. I don't know what the timing of it was. I don't know what supplements you're taking on top of it. I don't know if what I see in this panel, how that correlates to the rest of the system. Is it impacting your blood glucose regulation? Is it impacting, is this value, this range of values we see, it may be appropriate, it may be normal, but it may be abnormal, especially and no offense to the integrative and functional medicine community, but you have to be within this half a standard deviation or you're not healthy. That is the biggest BS in functional medicine, that you have to be here or you're not healthy. Labs are not the problem. Labs tell us a story. We just need to be able to interpret the story. If you only look at a value and say, if it's not in this range, but I'm only looking at this value, it's like ripping one page out of a book and thinking you know the whole book. So we can't interpret labs with just limited stuff. So the idea that we have to consider, we have to understand what normal is overall. Normal is for the state they're in. Like, what's normal and appropriate for the state they're in, right? What's normal and state for their age and appropriate for their age? What's normal and appropriate given this is going on in their life right now? What's normal and appropriate? I think too often, and I hope we can, and it sounds like you're trying to teach AI this, which is, yeah, TSH is elevated and T3 is low, but that's appropriate to this person's situation. We know this person's in this state. I just wonder, how do we teach AI that this is a person in overload state? This is a person is it just because we give them metrics and give them labs? Is it because we give them symptom questionnaires and health history things to formulate that they can then sense, hey, this is a person in overload, cell danger response. This is a person in a chronic strain state that's controlled or compensated. And this is a person who's in a chronic strain state that's now becoming unstable and is moving closer to that cell danger overload phase. Like, how does AI, how are we going to teach AI? Are they in resiliency? Are they in chronic stress? Is it cell danger? Because that determines this strategy, right? If they're in cell danger, I'm in triage mode. What do I got to do right now to get them out of this kind of danger physiology, threat physiology? If they're in chronic stress mode, right? Chronic strain load, but still kind of adapting to it, it changes my strategy, right? Because now what's our goal? Hey, I'm trying to optimize their health. You're trying to optimize what? You're not trying, that supplement you're giving them, the hormone you're giving them to optimize their health while they're in chronic strain isn't optimizing them. It's manipulating a lab value, but there's going to be consequences of that. We see that in thyroid physiology all the time. I'm optimizing their T3 to what? If they were in a resilient homeostatic state and they had a little bit low T3, then giving them a little bit T3, maybe that optimizes them. I'd question that. But I would also say, well, let's go back. Let's look at their genetics. They have genetic polymorphisms of deiodinase 2. So their trend is going to be that they're going to have lower T3 in their system. Is it something that a little bit more makes them feel better? Maybe. And that would be where that genetic data might come in and be helpful in pulling all that together. But we have way too many people trying to optimize people in a chronic strain state, or patients and people, and no offense to anybody who's listening, who are focused on longevity while they're in a chronic strain or overload state, and they're spending thousands of dollars a month on urolithin A and all these fantastic things that are awesome when you're in resiliency, but they fall short in chronic strain. And that's, how do we get AI? This is a long-winded question, but how do we get AI to know the state of the individual and provide strategies that are appropriate for the state they're in? Not the goal. I want longevity. Okay, well, you're not even there yet. It's like, I'm going to run a marathon today. Well, you haven't run even a half mile yet. I don't think that's a good idea. Do you understand what I'm saying? Whoever wants to take
Absolutely.
it.
Go for it, Susan.
I can say it because that's exactly what we've been doing. So I can actually speak on a lot of what you're talking about. One, on when you talked about the supplements, I had a woman come to me with in 10 years of practice, the longest supplement list I've ever seen. Everybody has a supplement graveyard, but this was the worst. And a lot of them were combination formulas. For me to go through and try to find overlap in that many, I was able to put all of that, and it's already got all of her data from her profile, labs, everything, to upload that into our AI, which is called CLIA. And it went through every bit of it and streamlined all of her supplements. Like, so this is an overload here, right down to.
Looks like we froze Susan.
And this could be.
Oh, there you go.
I'm frozen.
Okay.
Oh,
yeah, you good?
Okay.
Not a mind.
Okay.
Yes.
So it was able to streamline that. That was on a supplement thing. But I had a client come to me referred from a thyroid specialist, who I will not name, and she said, I can't do anything else with him because he was chasing the T3 and he couldn't
Hmm.
tolerate the T3. Well, when I looked at his labs, it blew my mind. He had a total cholesterol of 516. His LDL cholesterol was close to 400, and triglyceride 149, where we know the cutoff is about 150, is 150. And and having symptoms of slurred speech, blurred vision, extreme fatigue, inability to tolerate T3, just a past history of very serious kidney issues with kidney stones, and he'd been eating carnivore. He was eating ribeye steaks. That's all he was eating twice a day, and a lot of the times he wasn't eating until 9:30 at night. So immediately, all these red flags going off to me, and I said, we need to do deeper dive on labs. We need to go deeper on the lipids, which came up very alarming to me. And again, I'm not a practitioner, right? So I can use this to work with my lifestyle, the pieces of the lifestyle that I want. And our profile came up with very precise recommendations for him after putting all this in there. And within, well, so it said the same things I said. I said, I am very concerned about the state of this person because they've just been trying to chase thyroid on here. And it was like, you do not give thyroid medications to this person. They're not needed. This body is basically so out of balance. So it said the risk of ISAK with looking at the labs and these symptoms, which again, nobody was looking at, and his genetics. So I did his DNA as well. And the DNA was coming up with propensities around a lot of these genetics for increased risk for cardiovascular disease, with saturated fat, all of these things that he was doing. Long story short, the Clea had told me he needs to be referred to a cardiologist. We can work on the lifestyle part because no one's going to tell you not to work on lifestyle. But it changed the diet, bringing in vegetables, very specific vegetables, some fruits, which he was, of course, afraid to eat. And the exercise, the stress, bringing all of this into account, he was at an increased risk for ischemic stroke, cardiovascular event. And within a month, we retested labs. He had lost 15 pounds, but his cholesterol had dropped. Things were getting into a safer zone. But he decided to go to a cardiologist who is one who's on a lot of podcasts, and he touts carnivore. And they actually told him to go back to carnivore. And I said, but did you tell them about the symptoms you had? I don't know, because he actually didn't answer me. So my point in all of this is it allowed me to go deeper and see that everything we were doing with lifestyle, if I had just been looking at thyroid like the practitioner was, they're going nowhere. There was such a deeper, this onion, there were so many layers to peel of this onion on this body that were coming down to stress was a big one. The timing of the foods, putting all this stress on this body, eating a pound of ribeyes at 9:30 at night. Nobody was addressing it. Why is this? And why does it take me to have to go into an AI to pull everything together with all the genetics and see how high risk this person was?
But so I guess the question is,
how do you get AI to do that?
Well, yeah, how do we get AI to determine, because when you generally put in AI, does AI look at a low T4 or a high TSH or a high glucose as something it needs to fix? It needs to give it a response, or are we teaching? And maybe the issue is, obviously you guys have been talking about software. We'll get into what you guys maybe are talking about here shortly, because there's an issue. If we train AI one way, it says, oh, I just fixed that. Dude, somebody is the real issue going forward here. We need the AI to not just try and fix the problem, but do a better job than we're currently doing in traditional medicine, functional medicine, integrative medicine, into interpreting the why. Like somebody would say your blood sugar's high, your insulin is high, your hemoglobin A1C is high, you need to be on metformin or a GLP-1. That's a strategy, but that is a management strategy. What I want people to do is be able to find the AI support where it goes, hey, your fasting glucose is elevated, your hemoglobin A1C is up, and your insulin is, let's say in this situation, high. You can take insulin. You're already insulin resistant because you're glucose resistant. You could take metformin, but it doesn't create the issue. And that glucose resistance, now I've put in, we have your diet, your nutrition, what you're doing, you don't even eat carbohydrates. So your issue isn't a dietary issue, it's an inflammatory cell stress mechanism based on the intake paperwork that you gave me. Like I look at the 18 fitness factors, we'd say, okay, your emotional fitness is one of the weakest areas. Your physical fitness is one of the weakest areas. Your sleep fitness is one of the weakest. Your respiratory. These are the reasons why you're glucose resistant. So here's a path, here's another path, or we got to triage and do this path. All AI isn't going to do that, right? We have to find the appropriate AIs that are going to think holistically and from a recovery standpoint versus a management standpoint. Even in functional medicine, I would argue that maybe a good percentage of the people who are practicing as integrative or functional practitioners are just managers. They just use different hormones, peptides, and supplements. They're not helping people recover from a thyroid condition because they don't think they can. They're not necessarily helping people recover from a glucose issue. We're just giving microdoses of GLP-1. What our sweet spot is in functional medicine, and what I'm hoping AI, the right AI that we can steer people towards, is one that's not going to say you're diseased, you're dysfunctional, your body's broken, your immune system's attacking you, but one that says you're in overload, your body's defending you, you're not broken. Here's what we can do to help you heal and repair. And here's the strategies. I hope I'm saying, you understand what I'm saying?
And I've got an example.
That's what I'm experiencing. It never gives a medical, like a pharmaceutical approach. It's so much deeper than that. I can let Cam speak on this, but it gives options, and that's the beauty of it. But I've never used it where it has come from what you were describing as just this medical standpoint that we talked about on my podcast, a non-functional type of standpoint. Does that make sense?
Yeah.
But I'll let Cam speak on that to the technical part of what
I think
it does.
The point, Cam, is that people walk into an office and they're getting treated. Everybody gets treated the same.
Yeah, it's totally different.
But we don't understand the state they're in or what's creating it, so they all get treated the same. How do we prevent AI? And maybe AI is going to be just like a clinician, because if you get the wrong AI, you're going to get the wrong instruction. These are the things, and maybe that's the question. I'll let you answer this question, and then because we're short on time, we'll talk about what AI you guys are talking about, and maybe if somebody's going to, the big things if you're looking at AI for help, here are the things you have to consider so you're getting valid information. So first, answer that. The topic we were talking about, how do we train it? And then we'll get into the
beautiful
software you guys are talking about.
So the way that we need to train it is firstly in what are all the variations that we're likely to see in the humans that are going to walk into the office. Like, we need to have a structure and a framework for understanding what are the different types of people that are going to walk in. And I mean that, and we can talk about the most static data right through to the most dynamic. So even if you've just got, we'll just layer this in here. We've got just your genes in an AI, and that's the only information that you walk in with the medical history. And you say, great, I've got these symptoms. You go, great, okay, well, off these genes, off the information that we have, it's likely these three things. And this person's got different genes, could be likely these three things. But then you layer in, I've also noticed that your waist circumference, like we're now going to look at morphology. Your waist circumference has gone up significantly in the last 6 months. You have been exercising lots, which is kind of interesting. You have lost muscle tissue. So that's now genes plus their expression over time, but it's not moment to moment. It's now we're looking at 3 months of data of physiological stress. We know that ectopic fat deposition is happening, or like fat around the organs is happening because of the waist circumference. We know that there's inflammation and breakdown of the body because muscle tissue is dropping. So that's now extra data. We're then going to layer in, but then what's interesting about if we understand a skeletal structure, we know that like the wrist circumference to the ankle circumference, if someone comes in and they're skinny with a big belly, it's very different to the same belly size on a body with a very thick skeleton. Mm-hmm. So, and this is where genes and bones are very closely related in this sense. And if we understand, or what is a waist circumference relevant to that or relative to that person, that's another bit of data again. So everything is related to what does this data mean to the overall context of the person. Then we look at things like what are their disease histories? What have they had in the past? What have they had now? Do we have that information? Do we have labs? Do we have their wearable data coming in? Now, as you can see, as you layer more and more and more of all of this information, we have more and more context of the individual, so that when we have a symptom like a headache, with all of those layers of data, we can say, look,
isn't just aspirin.
Exactly. The answer is, likely it's the digestive system for this person. Likely it's muscular tension for this person, because we understand this morphology, we understand these genetics, we understand these pathways. The differential diagnoses are now completely different for these two individuals because we have so many layers of data. And that's where, I guess, the effort, and I say that we've gone to this effort, but the effort generally needs to be really, really good categorization and understanding of how people are different. Then number two, how do the symptoms and stress appear differently for these different individuals as well? And we need to understand mechanism for that too. And that's where we've spent the last 20 years sort of putting that picture together and doing that work. And then, and then the clinical expertise and the clinical agreements as well. This is very, very important that we have multiple practitioners from the same and different departments, silos of science, endocrinology versus cardiology, agreeing with, hey, we see this marker, it's likely this, and so this is where and then it's still only providing the information for the clinician right now. It's not taking the job over and going straight to the patient. It's saying, hey, clinician, consider this with the picture of the person that you are standing in front of and you have a feel for. And, like Chinese medicine was great for this. The best evidence was a 50-year practitioner, someone who'd seen it all, done it all, and their wisdom was very, very highly ranked. And I think we miss that in Western medicine, where we have incredible physicians that have incredible experience. Now, you add great information on top of a physician's intuition and a physician's experience. That's where we see a beautiful combination and a beautiful rub. So it's definitely not removing the clinician from this picture, but rather still using that human interaction to get those final bits of data. So that's a starting point.
So let's do this. Maybe we'll try to keep this answer short, tight. No offense to anybody, but we want to wrap this up
fair.
Here.
It's total good feedback.
You guys have developed, or you, Cam, I'm not sure who's behind the development of the software, but we'll talk about the software that you guys have been talking about. But is there any way? Because we don't want this like, yeah, our software is the only one that does it, right? Maybe it is, but how is anyone going to know what is a good software system or good AI to rely on in ChatGPT, Grok, whatever it is, PH360, like, how do they know? How is anybody going to know? This is, it's the same thing with how do they know what supplement's good? How do they know what doctor's good? How are they going to know what's a good software? to go to, or a good AI to go to?
On the surface, they're not. So that's the thing. As far as like if I type in a question and I get an answer, they are not going to know whether this is good information or not. So at the general population, a clinically trained mind would then be able to go and sift through the references that have been recommended. They could do their own sort of fact check on things.
Right.
That's going to take hours. And so then it's essentially we need a level of transparency into how does this system work. That's probably the way that this is going to happen, is that what has gone into this system to create what it is. And what we know about ChatGPT is that there's an incredible amount of hidden rules that we're not 100% sure of. And you write an answer and it'll give the answer that it provides. And definitely you can ask it about, hey, tell me the way that you're rationalizing this medical answer. And it will say, oh, I go and search for studies that relate to this. It actually steps out its thinking pretty well. But then where it's still lacking, and this is where a lot of evidence databases are lacking, is they lack granular individual data. And that's really where it becomes very, very powerful. So you need to be looking for a system that is based on granular, human, systematically collected data. Because you need that granularity in order to ask a specific question and get a specific answer. That's very, very important. So transparency in that. And then even looking at the methods that they've gone to supervise and manage the outputs. So, what process have they been through to train and supervise? That's also going to be another really important question that you're going to be asking of the data. Then you're going to be thinking, what's the security and safety? It needs to be meeting the international standards, and you can ChatGPT this, the international standards, but you want data to stay onshore. That's going to be a big deal. So onshore data not being transferred off to a server in somewhere else to be processed and then sent back, because there's all sorts of security issues that come when you go offshore. So you want to have onshore data servers that meet the standards. You then want to have the capacity for real-time data to be added, because if it's just static, it's out of date in 2 weeks. As far as, is this insight still relevant for me as well? So you need to have that integration. You need to have that integration of data as well. So on the surface, it's very, very difficult to understand. And this is probably the most difficult part of my job, is because before we'd been doing AI since 2011. This has not been a brief answer. I do apologize. I'm very aware, Eric. We've been doing AI since 2011. And for the first 10 years, I'm saying, hey, we're doing AI-driven health. And everyone's like, get that stuff away from me. That's freaky-deaky stuff. And then ChatGPT launched, and they go, oh, I've got AI health in my ChatGPT. And it's like, well, now the conversation is, well, what AI actually is it? So the brief answer is, it's very hard to tell. The second answer is, you need to go to the source of how was this engine built. That's essential. And you need to know what you're looking for as well. So obviously then evidence-based things that have got published literature around them, that's going to be helpful. Where there's been reputable people that have looked after the data set, that's going to be very, very helpful. That is, and I guess is this engine designed for human health? That's very, very important, because most engines are just large language models, and they're putting ideas together through language, not through clinical reasoning. And that's a very, very big difference too. So that's the starting point. Sorry for the length in that answer.
So let's talk about the software that you guys have been kind of alluding to. And then I don't want anybody to take this the wrong way, but if I go to your website and I look for all those things, am I going to get all those answers? Because those, and you may say, hey, we're not there yet, but these are the things that you're going to be looking for. And because we're talking about it, there's a software that you guys have used. Maybe there's competitors, I don't know. But it is, like I said, offline. This was a project that I started kind of dealing with somebody else. And then I quickly realized what the cost of building this thing was. And I'm like, now we're talking about getting venture capitalists involved and all this stuff. And I was like, I got people to take care of. I got books to write. But I do think it's the future. So what's the software you guys have been talking about? And does it provide the data when somebody goes there to tell them all the things you just mentioned?
So the first answer is we have all of those resources, that everything that I've shared today, that I guess what we're trying to do is set the standard for the way AI needs to be used, not just in the quality of the data, but also in the intention of the data. We want to see humans eliminate chronic disease and pain by 2050. We want to see humans have an experience where they are celebrated for who they are and they're living their best and most meaningful life. That is our intention. That's where we started 20 years ago. So, firstly, everything that we have spoken about today, not the stuff where there's the real-time HRV, it's telling me the music, it's mapped, and it's been something we've been talking about for the last 8 years. But the integration of the technology isn't there yet. So the actual hardware isn't there yet to make that possible. But everything around, can I understand this person? Can I layer in their genetics, their morphology, their real-time data, their wearables? All of that has existed in a medical sense for the last 2 years. And at a lifestyle medicine sense has been operating for the last, I've been teaching courses in this for the last 11 years. So this is very, very real, very established, I guess, data and technology that's been using AI insights for the better part of 13 years to help understand health. And so the organization is called the Shea Group. The technology is called PH360 or Shea for the user, and the clinician practitioner portal, Susan mentioned it before, but you would have missed it not knowing what it was. It's called CLIA, CLIA, Clinical Labs Interpretation Assistant. And if you go to the website, you'll see stuff that talks about the excitement of the technology. And then on further conversation with you, we provide information on our data security, on how the data is created, on all of those different things, on how we have collected 3 million human years of data, and with 10,000 data points per person minimum each time we assess them, plus their wearable data, plus now bloods. We do have 80 plus clinicians that are working through clinical questions in a blinded manner to improve the clinical thinking. We have had an academic team working on matching the evidence base from molecular biology to randomized control trials. For the last 18 years, we've been matching phenotype markers and outcomes with the evidence. So this is not an overnight thing. This has been, and this is where I can speak with quite a bit of confidence, knowing that we have a significant gap on the rest of the population, because we've been working on this for a long time. I hope that everybody has access to AI like this. That is the goal. And if our goal, if health happened for everybody tomorrow, we'd be saying job done. Like it just so happens that we've been wanting this to happen faster than others in a very, very intelligent way, based on the people that we've got on the team, that we've been able to put this together and have the foresight to actually collect this data and put this together the way that we have. So there is lots of other engines out there that are collecting incredible amounts of data. But it's the combination of the way that data is collected, the supervision that it has, and even the completeness of it, because we're looking at nutrition, exercise, environment, social tendencies, mental tendencies, the way that you respond to indoor places, outdoor spaces, the medical interventions, all of your different peptides and IVF or IV therapies. Like we're collecting data on that, as well as all of the conventional medicines and even natural medicine as well. So you can say, hey, I've got a Chinese medicine input here, a herb. How does that work with my conventional medicine? I've got light therapy over here. How can I support that? So we've gone as complete as we possibly can, because that's the answer does indeed need to be complete. So that's
you're making a platform, if this is fair to say, that is truly integrative, where it's looking at all three components. Like we're looking at the medical component and what we need to do for a triage perspective. And for the person that only wants triage care, it can manage that. If we have somebody who really wants recovery care and healthcare, we can be able to do kind of this software can look at a blend between the triage and the crisis management and the recovery processes that need to occur to actually get to a state of homeostasis and resilience, and potentially maintain that and support not just longevity, because living longer sicker is not great, right? We already have that.
Yeah.
But we have resiliency. And I think when people talk about longevity, what they really want is resiliency. I want to be resilient into my older years as opposed to anything else. So yes. I'll just kind of wind it up like this, because we're kind of pushing almost 2 hours, which I love. I mean, it wouldn't be my longest podcast, but I want to respect you guys' time. So my thought there's one of the things that I hope that people take away from today's conversation is that AI itself isn't the danger. A lot of people think it's going to be the problem. The real risk is what AI assumes health is and what we ask it to prioritize. AI can organize data, can identify patterns, and support awareness in powerful ways. But health isn't just about the numbers. It's not just about the genetics or the performance, about the capacity, the context, and the cost of adaptation. And that's why I think where we get that kind of that definition of health. And as AI becomes more integrated into healthcare, the responsibility isn't just building smarter tools. It's being clear about the goals we set, the assumptions we encode. And I think you talked about that. I'm glad you did. And when doing less is actually more precise care we can offer. And too often, especially in functional medicine, we think we always have to do more to fix things. And my argument with so many people, and I know Susan would agree with this, more times than not, less is better, not more. And I think we're more responsible for this, I think, than ever, with trying to take this, take that, take this. We blame medicine for what they're doing. And yet here we are loading somebody with 40 different bottles of supplements per day and saying, hey, this is going to help you. No, and it's probably going to drive you poor. So I do think AI is the future. I think it's now, I think it's the future, but I think people have to be very cautious of what they put into this, what they put in, and to be able to interpret what they get out. And then but I do think there's going to be lots of platforms like the one you have. And I think, I don't know much yet, and I haven't looked at their program yet, but it sounds exciting. But I think it's going to come down is if you're going to use AI to help you, it really does come down, from my perspective, what have we taught that AI? How have we taught it to integrate? How have we taught it to interpret? How have we talked about the individual state? Are we just looking at labs? Are we just trying to manage something? Or are we trying to move somebody towards recovery? And does that AI understand those dynamics? So it's not just here's another pill faster, but here's the strategy to get you from here to there with less, not more. So I appreciate you guys coming on the podcast. I think it's a great conversation. Probably could have done another couple hours easily, but I appreciate you coming on. Thank you so much.
Thanks for having us.
Thanks, Eric.